Greetings to everybody. I'm Dr. Samiksha Kanuja, Associate Professor, HIMSR, New Delhi, and I'll be talking about a patient with an obstructive lung disease for surgery, its therapy and intensive care. And I have divided my lecture into two modules. So this is the part one where we will be talking about the patient, about the obstructive lung disease, the diagnosis of this disease, and how do we go about if we are planning this patient for any particular surgery. So we all know that obstructive lung diseases in all its form, they represent the commonest pulmonary disorder that an anesthetist encounters. Pulmonary complications after surgery are the leading cause of postoperative morbidity and mortality. So screening for pulmonary risk factors proceeds on the basis of clinical history and physical examination, and then the results can together be combined with the knowledge of the proposed surgical procedure, and in turn we can dictate an appropriate preoperative management. So we need to know the pulmonary risk factors. We will combine them with the history of the patient, the physical examination of the patient, and together with what kind of surgical procedure we are planning to do on the patient will guide us and take us to the appropriate preoperative management that we need. So what is COPD? What is the working definition of COPD? COPD is basically considered in any patient who has dyspnea, chronic cough, or sputum production, and or a history of exposure to risk factors for the disease. Again, a patient who has dyspnea, chronic cough or sputum production, and or a history of exposure to risk factor for the disease. These three things together, they combine to make a COPD. For the diagnosis, we require spirometry, yes, in the clinical context, where we say that post bronchodilator, when the FEV1 to FVC ratio is less than 0.7, we will have a confirmatory for the presence of persistent airflow limitation. This ratio, when it is less than 0.7, it is just the confirmatory that yes, there is a persistent airflow limitation that is present, which has not been completely corrected even with the bronchodilators. So this, together with the patient who has got the appropriate symptoms and yes, the significant exposure to noxious stimulus, is what leads us to the diagnosis of COPD. So the key indicators for COPD: dyspnea, which is progressive over time, which will characteristically get worse with any exertion or exercise, which is persistent. Chronic cough, which may be intermittent, may be unproductive, may be associated with recurrent wheeze. Chronic sputum production. Now the sputum can have any pattern, and any pattern will indicate kind of COPD only. Recurrent lower respiratory tract infection. Any history of associated risk factor, be it the host factor, which may be genetic, congenital, any developmental abnormality, tobacco smoke, smoke from home cooking, heating fuels, any kind of smoke, any kind of occupational dust, fumes, gases, and family history of COPD or some childhood factors is also contributory towards making a diagnosis of COPD. Like the patient has a history of low birth weight or history of recurrent childhood infections, respiratory infections. So this is the pathway that takes us towards the diagnosis of COPD. Patient complaining of the symptoms, three which I talked about: shortness of breath, chronic cough, and sputum. This, when we combine with the risk factors, the host-related factors, tobacco, occupational, indoor-outdoor pollution, and when we take these two together and do a spirometry for our confirmation, where we get an FEV1 to FVC ratio less than 0.7, post-bronchodilator therapy, very important, we come to the diagnosis of our COPD. Now, the Gold Report of 2020 has given this particular spectrum where we can just briefly talk about the etiology, pathobiology, pathology, taking us towards the airflow limitation. Etiology, we know what it is. Pathobiology is when there is an impaired lung growth, accelerated decline of the lung injury, lung and systemic inflammation, when these are happening. Pathology, when there is a small airway disorder or abnormality, emphysema, any systemic effects that we are seeing in the patients. All this having the clinical manifestation of the usual symptoms of COPD, symptoms in the form of exacerbations, or when the patient has associated comorbidities and an associated airflow limitation, persistent airflow limitation. So all this combined together have taken us towards the COPD. By the American Thoracic Society, the spectrum of COPD has broadly, I would use the word broadly, it's a very broad and a very, overlapping classification that is there of COPD, emphysema, chronic bronchitis, and small airway disease. Emphysema is defined pathologically as the dilatation of the air spaces beyond the terminal bronchioles with the destruction of the walls, but without any obvious fibrosis. Chronic bronchitis is defined clinically as chronic cough with sputum production for more than 3 months each year over the previous 2 years. And small airway disease is a condition in which the small bronchioles are narrowed. Now, what is COPD exacerbation? When do we say that the patient has had an exacerbation of COPD? Any event in the natural history of the disease which is characterized by a change in the patient's baseline dyspnea, cough and or sputum production which is beyond the normal day-to-day variations and is acute in onset, anything which is warranting a change in the regular medication in a patient with an underlying COPD, increased hyperinflation and gas trapping with a reduced expiratory flow, and worsening of VQ, that is ventilation perfusion abnormalities or VQ mismatch, which can ultimately result in hypoxemia. So any of these things, if it has happened in the patient, is probably when the patient is going to present to the hospital, is when we say that COPD exacerbation has happened. Now, what are the risk factors for developing COPD? Cigarette smoking, the most important and common risk factor. Though there is a considerable variability in response to smoking, what we know about smoking is the word pack years. Now, pack years of cigarette smoking is basically the most significant predictor of FEV1. But whatever variability that has been observed with respect to pack years and cigarette smoking, it has only been 15%. So that means there are additional environmental and genetic factors also that contribute to the impact of smoking on the development of airflow obstruction. And again, as I told you, any kind of occupational exposure, ambient air pollution, very important cause these days. Passive or second-hand smoking, again, it's a question mark over here. Respiratory infections, which are a very important cause of exacerbation of COPD, and genetic consideration, that is alpha-1 antitrypsin deficiency. It's a very rare possibility where only 1 to 2% of the COPD patients will have this genetic factor which have a profound influence on the susceptibility of developing COPD, but still it is one of the risk factors. Now, the presentation of COPD as earlier described was into broadly two categories, pink puffers and blue bloaters. Pink puffers, which are emphysema predominant, blue bloaters, which are bronchitis predominant. Again, there is a lot of overlap in that. If we talk about the clinical features, the pink puffers will be the ones who are breathless, who will not have central cyanosis, who will have chest hyperinflation, and if you look grossly at these patients, they will usually be underweight, they will be thin. On the other side, the blue bloaters, they will not be breathless at rest, they will have severe central cyanosis, hence the name blue bloaters. They will have all the features of right-sided heart failure, not will have, might have, like cor pulmonale, ankle edema, hepatomegaly, raised JVP. These patients will be frequently overweight. If you talk about the blood gases, in pink puffers, PaO2 would be normal or might be slightly reduced, but saturation is normal at rest. PaCO2 is again normal or slightly reduced. Whereas in blue bloaters, the PaO2 is reduced, the PaCO2 is slightly to markedly elevated. Chest X-ray. In pink puffers, we will have hyperinflation where we'll have flat diaphragms, horizontal posterior ribs, small heart shadow, which we typically call as the tubular heart, which is very properly seen in emphysema patients. Blue bloaters, they will not have very specific X-ray pictures. They will have like increased interstitial markings, probably the dirty lungs, especially at the bases. Diaphragms will not be flattened. Cardiomegaly may be present. Red cell count will be normal in pink puffers. There will be secondary polycythemia in blue bloaters. The hemodynamics will be comparatively normal in pink puffers, like normal resting PA pressures, normal cardiac output, whereas as I told you, the signs of right-sided heart failure, where pulmonary hypertension and slight elevation of cardiac output at rest, it will be seen in the bronchitis patients. Control of breathing. The emphysema people, they have the normal ventilatory drive, whereas there is a retention of CO2 and in turn reduced ventilatory drive in bronchitis patients. Diffusing capacity is reduced in patients with bronchitis. Prognosis is relatively better in the patients with bronchitis as compared to the patients with emphysema. So this is the pathophysiology summarized of COPD, where we've had inflammation. Now this inflammation, the causes we've already said why we've had inflammation. What has this inflammation led to? This inflammation has either led to a small airway collapse, where there is chronic mucosal inflammation, excessive bronchial secretions that led to mucosal plugging and hence remodeling of airways, ultimately leading to increased transmural pressure gradient during forced exhalation. Or it led to the parenchymal destruction, where there was loss of alveolar attachments, loss of opening traction on airways, decreased elastic recoil. Ultimately, these all together, singly or in combination, have led to what? Have led to the severe airflow limitation. So, what has it actually led to? The consequences of these changes is incomplete expiration, gas trapping within the lungs, with a positive alveolar pressure at the end of expiration, that is, an auto-PEEP. In patients who are breathing spontaneously, this auto-PEEP must be overcome before the next inspiratory flow can begin. Hence, this will further add to the work of breathing. Whereas in the patients who are mechanically ventilated, this auto-PEEP will promote an unsuspected increase in intrathoracic pressure, ultimately leading to your reduced venous return, reduced cardiac output, and hemodynamic instability of the patient. So this auto-PEEP, in turn, this work of breathing, it can be reduced and the mechanical efficiency of the respiratory muscles can be improved by the therapies which reduce this airflow limitation and reduce this gas trapping. So we have to aim at these two things mainly, the therapies which will reduce the airflow limitation and the therapies that will reduce the gas trapping. Coming on to the preoperative evaluation for a patient who has got a pulmonary disease, any general pulmonary disease. Very important, most important is your history taking. As we know, the most important symptoms of the respiratory disease are cough, sputum, breathlessness, hemoptysis, wheeze, chest pain. Cough, what is cough? After there is a rapid increase in the intrathoracic pressure because of the contraction of respiratory muscles against a closed glottis, the glottis opens with an explosive release of air into the upper airway. And this is what cough is. It can be stimulated by some chemical irritants, smoke, increased secretions. It can be dry or it can be productive, either with sputum or with blood. Now, the sound of cough itself can be very helpful in making any particular diagnosis. For example, a nocturnal cough may indicate an asthma or pulmonary edema. Recurrent laryngeal nerve palsy can cause bovine cough. Intrathoracic neoplasia can cause Braucy cough. Second symptom is your sputum. What is sputum? Sputum is the expectorated respiratory secretion. Now we know that normal lung produces around 100 ml of clear sputum each day, which is transported to the oropharynx and is then swallowed. Bronchoria is when there is an excessive production of secretions. Now the estimate of the daily volume of sputum should be made. It's very important. Smokers, what happens is that they will falsely consider their morning cough and sputum production to be normal, but actually it is not. Third symptom is your hemoptysis. What is hemoptysis? Expectoration or coughing up of blood or blood-stained sputum from the bronchi, larynx, trachea or lungs. Causes can be any: neoplastic, infective pulmonary disorder, cardiac disease, acute respiratory infection. We can see catastrophic bleeding in bronchiectasis, aspergilloma, tuberculosis. What is massive hemoptysis? Now, when over a 24-hour period there is an expectoration of more than 100 to 600 ml of blood, Any amount which is hemodynamically so significant or is threatening ventilation to a level where our initial management goal will not be diagnostic but therapeutic is what we call as the massive hemoptysis. Next symptom, very important, breathlessness. Now, what is breathlessness? It is a subjective or an undue awareness of breathing. Now, breathlessness inappropriate to the level of physical exertion or even occurring at rest is called dyspnea. Dyspnea is more specifically defined by ATS as a subjective experience of breathing discomfort which consists of qualitatively distinct sensations that vary in intensity. It's basically an interaction among multiple physiological, psychological, social, environmental factors, and it may induce secondary physiological and behavioral responses. Now, objective measurement of this dyspnea is very difficult, but it may be quantified by asking the patient like how many stairs can you climb without stopping. So these are the broad classifications of dyspnea that have been given. Say, for example, one is the Roisen's classification of dyspnea, where we've got 5 grades. Grade 0, where there is no dyspnea while walking on a level at a normal pace. Grade 1, where the patient says, I'm able to walk as far as possible, provided I take my own time. Grade 2, where there is a specific street block limitation. That is, after walking for say 1 or 2 blocks, I have to stop for a while. Grade 3, where there is dyspnea on mild exertion, like I just feel breathless and have to stop even from kitchen to bathroom. Grade 4 is dyspnea at rest. Second is your classification given by Medical Research Council. 3 grades. Grade 1, breathless while hurrying up on the level or walking up a slight hill. Grade 2, breathless while walking with the people of your own peers on the level ground. Grade 3, where the patient has to stop because of breathlessness, even walking on a level ground, even at the own pace. Next is the most important ATS grade of dyspnea. 0, 1, 2, 3, 4. 0 is none, no shortness. 1 is mild, shortness while hurrying on the level or walking up slight hill. 2 is moderate, walking more slowly than the people of the same age on the level because of breathlessness or has to stop for breath walking at the own pace on the level. 3 is severe, stopping for breath after walking say 100 yards. And 4 is very severe, too breathless to even leave house or dress and undress. Coming on to the next, physical examination. The physical examination starts right when you are taking the history. While you are taking the history, while the patient is telling you his or her history, you are observing the patient's appearance. What are you observing? You're observing that is the patient breathless at rest or in conversation? Is there any audible wheeze? What is the resting respiratory rate? Does the patient look anemic, polycythemic, or cyanosed? Can you see any kind of clubbing or nicotinic stain on the fingers? Inspection. In inspection, what will you see? Central cyanosis, which is the bluish discoloration of the mucosal membrane, which is very difficult to detect in artificial light and in many racial groups as well. Common chest wall abnormalities, which might reflect the hyperinflation of the lung in COPD, which include relatively horizontal ribs, barrel-shaped chest, protruding abdomen. Flattening of hemidiaphragms, which may be associated with paradoxical indrawing of the lower rib cage on inspiration, widening of the sternal angle. You can see all these things. Resting respiratory rate, which is often increased to more than 20 breaths per minute, and relatively shallow breathing. Pursed lip breathing, which serves to slow the expiratory flow, permit more efficient lung emptying. Often having the use of resting muscle activation while lying down supine. Further indicator of any respiratory distress is when you can see the use of scalenii and sternocleidomastoid muscles. Then ankle or lower limb edema, which can point towards the right-sided heart failure. Measurements of the chest. Rate of respiration, rhythm of respiration, chest expansion during inspiration, expiration, your both anterior, posterior and the lateral dimensions. You have to take the ratio of your AP to lateral the dimensions. How is the ratio affected in what kind of respiratory disease? You should know what is the normal AP to lateral ratio. Palpation, where we can see the tenderness and the local rise in temperature. The tracheal position, cardiac impulse detection, which may be difficult because of lung hyperinflation. The symmetry of expansion of lungs. Tactile or vocal phlegmatis. Percussion, where you see the resonance or dullness. So as you can see in these figures, you should know how to do all these things, how you are testing the symmetry of the lung expansion from the anterior side, from the posterior side. This is how you are assessing the tactile fremitus. These are the areas where you palpate the tactile fremitus. This is how you are testing for your cricosternal distance. Auscultation, very important. In auscultation, what we are seeing the breath sounds, vesicular, bronchial, which are often overall reduced in COPD because of pulmonary hyperinflation. Your vocal resonance, bronchophony. What is bronchophony? Where vocal resonance seems to be near the earpiece of the stethoscope. Agophony, where it is heard over the consolidation above the level of pleural effusion. Whispered pectoraliqui, increased loudness of whispering which is noted during the auscultation with a stethoscope on the lung field on the patient's back. Then we look for any added sound, be it to rub, wheezes, crackles. We should be able to differentiate these different kinds of sounds. So these are the auscultatory findings which we should know. The bronchial breath sounds. What are tubular breath sounds? Tubular breath sounds are the breath sounds which are transmitted to the periphery. What is egophony? What is bronchophony? Pectoraliqui, crackles. Crackles are the discontinuous sounds that are heard on auscultation. Coming on to the assessment of pulmonary functions. Now, pulmonary functions are assessed by pulmonary function tests, which are the group of tests used to diagnose and quantify the presence of a respiratory disease. Now, unlike asthma, COPD does increase the risk of postoperative pulmonary complications. Severe the COPD, greater the risk, but there is no prohibitive degree of severity that will preclude the surgery. This you have to remember. Although COPD increases the postoperative pulmonary complications, the risk that the patient has because of only COPD is less than when it is associated with patient-related risk factors like CHF, advanced age, or poor overall general health status. Now, higher risk for non-pulmonary complications such as wound infections and atrial arrhythmias might be there. Preoperative spirometry may be useful in these patients to assess the severity of the disease and the adequacy of bronchodilator therapy, but only in the patients in whom it is difficult to determine this from the history and physical examination. Normally, our history and physical examination will only lead us to assess that what is the grade of COPD the patient is, what is the severity of the COPD in the particular patient. So as they say, even before a high-risk surgery, there is no role for routine PFTs because there is nothing what a history and a careful physical examination will not tell. Spirometry is usually only adding any information, a little bit to it, nothing more beyond than that is obtained by the careful history and the physical examination. Patients who got severe COPD as determined by the spirometric values are unlikely to escape any clinical detection. So these are few of the bedside PFTs that are done: Snyder's match blowing, forced expiratory time, Sabry's single breath count, Sabry's breath holding test, cough test, De Bono's whistle test, Wright's peak flow meter. Breath holding is, what is it telling? It tells about the vital capacity of the patient. And normally 25 to 30, more than 25 it is taken to be acceptable. And as we go below 25, the vital capacity is decreased, the risk of acidosis in that patient is higher. That is how it is tabulated. What do we see in an X-ray of a patient with COPD? Suppose this is the X-ray that we are seeing. This is the classical picture of a patient with emphysema. So what do we see? We see an increased lucency of the lung fields. In smokers, it will be more prominent in the upper zone. In alpha-1 antitrypsin deficiency, it will be more in the basal zone. We might see bullace, that is the localized radiolucency, more than 1 centimeter in diameters and surrounded by the hairline arcuate shadows. We might have some features of pneumothorax in case any bulla has ruptured. The chest, as you see, is vertically elongated with low and flattened diaphragm, hyperinflation. The heart shadow is vertical and narrow. There might be features of pulmonary hypertension, that is, pulmonary arteries, they become enlarged and they are tapering rapidly, pruning. Prominent hilar markings with loss of peripheral vascular shadows. Right-sided heart failure. heart border, which is more prominent, and as you can see, it is impinging upon the retrosternal air spaces. As I previously told you, in a patient with chronic bronchitis, you won't have any typical picture of X-ray. What you will see is just a dirty lung field, increased interstitial markings. HRCT scanning, which is more sensitive than standard chest radiography, and it is very specific for diagnosing emphysema because the outline bullae, they might not be properly seen in an X-ray. Most of the time, they will just escape. ECG in COPD. What do you look for ECG in COPD patients? We have to look for an evidence of any right atrial or ventricular hypertrophy, any evidence of cor pulmonale. Strain pattern might be present like ST depression, inverted T waves in lead V1 to V4. We can have P pulmonale, that is tall P waves more than 3 mm. Right axis deviation, we can have prominent R waves and T wave inversions in right chest leads. Now, classification or staging of COPD based upon the severity, which was given by the American Thoracic Society. So this is based upon the percent predicted bronchodilator FEV1 when FEV1 to FVC ratio is less than 70%. Now, in the Gold report of 2001, there was another category called stage 0, which was an at-risk COPD category. This is no longer included in the stage of COPD as there is an incomplete evidence that individuals who meet the definition of at-risk COPD, that is having chronic cough and sputum production with normal spirometry, will necessarily progress to stage 1. But this again cannot deny the importance of public health message that chronic cough and sputum is not normal, and this importance is still unchanged in the latest 2020 guidelines of Gold report. Classification is 1, 2, 3, 4, mild, where FEV1 is greater than equal to 80% of predicted, 2, moderate, FEV1 less than 50, greater than 50% of predicted, 3, severe, where it is between 30 to 50% of the predicted, and 4 is very severe, where the FEV1 is less than 30% of the predicted, or FEV1 is less than 50% and there is a chronic respiratory failure. The GOLD classification, the GOLD initiative of obstructive lung disease, where we've got again specific spirometric cut points. The spirometry is performed after the administration of an adequate dose of at least one short-acting inhaled bronchodilator to minimize the variability. Now, there is only a weak correlation between FEV1 symptoms and impairment of a patient's health status. Hence, a formal symptomatic assessment is a must. So these are the 4 classes of GOLD: mild, moderate, severe, and very severe. %, less than 80%, 30 to 50%, and less than 50%. Board index. What is board index? Board index, it's a composite marker of a disease taking into consideration the systemic nature of COPD as well. And it is going to predict all the cause, mortality and respiratory related mortality with better accuracy than when we were doing it with FEV1 alone. Based upon the board index, we calculate the 4-year survival, where we have 0 to 2 points as 80%, 3 to 4, 67%, 5 to 6, 57%, and 7 to 10 as 18%. Board B is your body mass index in kg per meter square, where if the score is 0, it's less than 21, and for all the other 3, it's more than 21. O is your obstruction, FEV1 post bronchodilator. 0 more than 65, 1 50 to 64, 2 35 to 49, and 3 less than 35. D is your dyspnea scale, MRC. 0 to 1, 0, 2, 1, 3, 2, and 4, 3. And E is your exercise capacity as judged by the 6-minute walk distance in meters. 0 is more than 350, 1 250 to 350, 3 150 to 250, and 3 is less than 150 meters. Management of COPD. Now, how do you go about by management of COPD? There are 4 steps in the management. You assess and monitor the disease, you reduce the risk factors, you manage the stable COPD, and you manage the exacerbations. Again, 4 things. We assess and monitor the disease, we reduce the risk factors, we manage the stable COPD, and we manage the exacerbations. Now, how do we assess and monitor the disease? We consider the COPD and perform spirometry if any indicators which we've discussed earlier are present along with the age more than 40. All this will increase the probability towards the diagnosis of COPD. Yes, spirometry is needed to establish a diagnosis of COPD, where post-bronchodilator FEV1 to FVC less than 70 of the predicted and FEV1 to less than 80% of predicted will confirm the presence of airflow limitation, which is not fully reversible. So stage 1, which is mild COPD, or stage 2, which is moderate COPD, may not come into medical facility until their airflow limitation has become more severe or their lung functions have been acutely worsened by the respiratory infection. Now, as this airflow limitation worsens, the patient will enter stage 3, which is severe COPD, where the symptoms of cough, sputum production will typically continue, dyspnea will worsen. Additional symptoms heralding complications like respiratory failure, right-sided heart failure, weight loss, arterial hypoxemia may develop. Coming on to the third step, where we need to reduce the risk factors. Now, smoking cessation is the single most effective and cost-effective way to reduce the risk. Intervention in most people to reduce the risk and even to stop its progression. Again, we have to have the strategies aimed at reducing the burden of inhaled particles and gases as well. Third, how do we manage a stable COPD? Now, none of the existing medications for COPD will modify the long-term decline in the lung function, which is the hallmark of this disease. Pharmacotherapy that we use is only aiming at reducing the symptoms and its complications. Bronchodilators are central to the symptomatic management. They are given as need basis or on regular basis to prevent or to reduce the symptoms and exacerbations. We have beta-2 agonists, we have anticholinergics, we have methylxanthines, which are used singly or in combination. We should remember that regular treatment with long-acting bronchodilator is more effective and convenient than the short-acting bronchodilators. Addition of regular treatment with inhaled glucose steroids is appropriate for symptomatic COPD patients when they have reached stage 3 and 4 or are having repeated exacerbations. Chronic treatment with systemic glucocorticoids should be avoided because they have an unfavorable benefit to risk ratio. Benefit from exercise training programs improving with respect to both exercise tolerance and symptom of dyspnea and fatigue. So this is in brief about the different drugs that we use for the symptomatic management of COPD. Beta-2 agonist, how do they act? They act by relaxing the airway smooth muscles, by stimulating the beta-2 adrenergic receptors, increasing the cyclic AMP, and producing an antagonism to bronchoconstriction. They are rapid in onset, and the oral therapy, though, is slower, but will have more side effects as compared to the inhaled treatment. And you have both. You've got short-acting beta-2 agonists, you've got long-acting. Short-acting, you've got salbutamol, terbutaline. Long-acting, you've got salmeterol, famotidine. The adverse effects, as we all know, there can be resting sinus tachycardia, cardiac arrhythmias in susceptible patients. And there is some query as to do these beta-2 agonists also lead to an increased oxygen consumption? Second category of the drug is the anticholinergics. How do they act? They act by blocking the acetylcholine effects on the M3 receptors. Now, the current short-acting drugs, they also block the M2 receptors and they will modify the transmission at the preganglionic junction. They are again short-acting, long-acting. Short-acting, we've got ipratropium bromide, oxytropium bromide. Long-acting, we've got tiotropium. Dryness of mouth, occasional prosthetic symptoms, bitter or metallic taste. And these are some known side effects that we've got with the use of anticholinergics. Methylxanthines. Methylxanthine, we know, are the non-selective phosphodiesterase inhibitor, and they might also act by blocking the adenosine receptors and blocking the release of endogenous catecholamines. They have some adverse effects as well, like they've got a dose-related toxicity, and they might sometimes in susceptible people lead to atrial or ventricular arrhythmias, headaches, insomnia. We've got aminophylline, which is used in an acute exacerbation in a loading dose of 5 mg per kg over 30 minutes, followed by 0.5 mg per kg per hour as a continuous infusion. Then we've got theophylline, sustained release. Glucocorticoids. The effect of oral and inhaled steroids is much less dramatic than in asthma. And in advanced diseases of COPD, regular inhaled steroids have been shown to even reduce the frequency of exacerbations. It is recommended for only advanced COPD and in the patients who are having repeated exacerbations. Adverse effects, yes, we'll have mainly with the long-term systemic steroids. Steroid myopathy has been known. Examples of these are beclomethasone, budesonide, fluticasone. Now, the COPD patients, on the basis of their risk, on the basis of their symptoms, have been categorized into 4 categories. Group A are the patients who have got few symptoms and are at a lower risk of exacerbation. Group B, who have got more significant symptoms but are still at a lower risk of exacerbation. So in these 2 groups, the recommended first choice of treatment are your short-acting anticholinergics or short-acting beta-2 agonists, and in group B, long-acting anticholinergic or long-acting beta-2 agonist. And as an alternative, we can add whatever is not being used in the first choice, the second option to that. And the other possible treatment is again theophylline if these 2 don't act. Group C are the patients who have got few symptoms but at a high risk of exacerbation. There, the first line of treatment is actually the inhaled corticosteroid, the long-acting beta-2 agonist, or a long-acting anticholinergic. If not getting relieved, we can add a long-acting anticholinergic and phosphodiesterase 4 inhibitor. And the other possible treatment is short-acting beta-2 agonist. Short-acting anticholinergics can also be added to them. Group D are the patients who have many symptoms and are at a very high risk of exacerbation also. The first line treatment again inhaled corticosteroid, long-acting beta-2 agonist and or long-acting anticholinergic. And we can add in them, in the resistant cases, carbocysteine. Again, the short-acting ones can be added, theophylline of course, long-acting anticholinergics and phosphodiesterase 4 inhibitors also. So, how does in COPD patient, what are the precipitating factors for leading to the exacerbation? When can a patient land an exacerbation? He can land an exacerbation if there is an acute infection, non-compliance of the prescribed drug in the post-operative phase, very important for us. If pneumothorax or pleural effusion from any other cause develops, atelectasis, again post-operatively, trauma, sepsis, pulmonary thromboembolism, pulmonary edema. All these can take the patient into the exacerbation phase. So what will be the signs and symptoms of severe exacerbation? There will be use of accessory respiratory muscles, paradoxical chest wall movements, worsening or new onset cyanosis, development of peripheral edema, hemodynamic instability, signs of right-sided heart failure, reduced alertness. So this is how we have managed the COPD. How will you manage the exacerbations of COPD? This starting on with this part from where we will be talking about the management of exacerbation of COPD, the ICU care and all, we will be talking about in the second module.